Welcome to our 4-part series on positive behaviour support for people with developmental disabilities. Before we dive into strategies and techniques, let's start with an honest question. Is it possible for people to change their behaviour? If you've ever made a New Year's resolution and broken it by January 15th, you know the answer. Behaviour change is hard. And if it's hard for us, imagine how hard it is for someone who's been doing the same behaviour for years. Maybe their entire life, and that behaviour has been reinforced over and over. That's why positive behaviour support doesn't expect overnight miracles. We're not looking for perfection. We're working toward progress. Today, you'll learn what makes positive behaviour support different from traditional approaches and why it's more effective for creating lasting change. The old way, medical model. Traditionally, challenging behaviours were handled using a medical model. The medical model says, this person has a problem, an expert will fix the problem. It views challenging behaviours as symptoms of an underlying disease or diagnosis. Example of medical model thinking. Joe acts out because he has a schizophrenia. That's just how he is. The assumption is that the behaviour comes from the diagnosis and an expert needs to prescribe the solution. Problems with this approach: it's expert-driven, not person-centred. It doesn't ask why the behaviour is happening. It treats the person as passive, something to be fixed. It ignores context, environment, and the person's unique life. PBS says, behaviour serves a purpose. It's goal-directed. Every behaviour, even challenging behaviour, is the person trying to communicate something or achieve something. PBS is holistic because it looks at the whole person, their unique physiology, their situation and environment, their developmental history, their psychological needs, their thoughts and feelings, their culture and values. And most importantly, the person is at the centre, not the expert, not the diagnosis. The person, their family and their supports drive the plan. This is what makes PBS comprehensive and effective. Positive behaviour equals desirable, adaptive, pro-social behaviour. Behaviour that helps the person make progress in their life. Support equals encouraging, strengthening, building on what's already working. Not using aversive tactics, humiliation or punishment. Key principles of PBS. Start with functional assessment. Functional assessment is an information gathering process. We ask, why is this behaviour happening? What purpose does it serve? We'll cover this in depth in later videos. Use comprehensive interventions. We don't rely on one technique. We use proactive strategies. Teach new skills before problems happen. Intensive support when needed. Crisis plans for safety. Reactive strategies when behaviour occurs. Focus on lifestyle enhancement. Improving quality of life is the cornerstone of PBS. When people feel happier and more fulfilled, challenging behaviours decrease naturally. Team approach. When possible, we collaborate. Support staff, family, medical providers, employers, everyone works together. Applied behaviour analysis analyses the interaction between purposeful behaviour and the environment. It uses data collection, reinforcement, and systematic teaching. So what's different about PBS? PBS includes everything ABA does plus additional elements. Think of it as ABA plus. What PBS adds? 1. Normalization and inclusion. The person lives in their natural environment. They're included in society, schools, work, community, not isolated or segregated. 2. Person-centered and family-centered values. The person's preferences drive decisions. Family values are honoured. The person directs their own life. 3. Contributions from multiple disciplines. Medicine and biology, developmental psychology, neuropsychology, social work, education. Bottom line, PBS includes BA methods, but goes beyond them to address the whole person in their whole life. Let's look at what actually happens in a positive behaviour support approach. Component 1. Teaching is the foundation. PBS is proactive. We teach expectations, acceptable behaviours, and new skills before problems occur. We don't wait for the person to fail and then punish. We set them up for success by teaching what to do. Component 2. Build on strengths. PBS is strengths-based. We identify what the person already does well and build on it. Example, if someone is great at following visual schedules, we use visual supports throughout their day. Component 3. Ongoing monitoring. We collect data on problem behaviours. We track patterns. We analyse what's working and what's not. This is where ABA methodology is integrated into PBS. Component 4. Data-driven decisions. We don't guess. We look at the dates and adjust strategies based on what the evidence shows. If something's not working, we change it. If it's working, we keep doing it. Component 5. Intensive support leading to independence. We provide intensive support initially, then systematically fade it as the person develops skills. The goal is always independence, the person managing their own behaviour successfully. Component 6. Quality of life focus. This is the cornerstone. When people have meaningful activities, positive relationships, choices, and dignity, challenging behaviours naturally decrease. We don't just reduce problem behaviours, we increase life satisfaction. Component 7. Integration into daily life. Skills learned in PBS are integrated into real life, real settings, real situations, not practiced in therapy rooms and then expected to magically transfer. Understanding readiness to change. Here's something critical that many behaviour plans ignore. People change at different rates and they need to be ready. The stages of change model helps us understand where a person is in their readiness to change. Stage 1. Pre-contemplation. Characteristics. Denial. I don't have a problem. Poor awareness. Rebellion. Don't tell me what to do. What the person might say. There's nothing wrong with what I'm doing. Everyone else is the problem. Your approach at this stage. Education and awareness raising. Gentle. Non-confrontational. Help the person see the discrepancy between their goals and their current behaviour. Don't push. Don't argue. Build trust. This is the hardest stage because the person isn't committed to change yet. Stage 2. Contemplation. Characteristics. Ambivalence. Mixed feelings. I want to change, but stuck between wanting change and staying comfortable. What the person might say, I wish I could stop doing this. I want things to be different, but I don't know if I can. Your approach at this stage, explore the function of the behaviour. Help them understand why the behaviour developed. Don't dwell on negative consequences. Focus on what they gain from change. This is where hope starts to emerge. Stage 3. Preparation. Characteristics. Taking small steps toward change. Making concrete plans. Gathering resources. What the person might do. Start therapy. Make small changes to routines. Talk about specific goals. Your approach at this stage. Support planning and preparation. Help them take concrete steps. Build confidence. Celebrate small wins. This is where behaviour change becomes realistic. Let's review what you learned today. First, PBS is different from the medical model. It's holistic, person-centred, and views behaviour as goal-directed and functional. Second, PBS is ABA+. It includes behavioural analysis plus normalisation, inclusion, person-centred values, and multiple disciplines. Third, key components include teaching as foundation, building on strengths, data-driven decisions, and quality of life focus. Fourth, understanding readiness to change, pre-contemplation, contemplation, preparation, helps you know where to start and what interventions will work. Remember the core principle, we're working toward progress, not perfection. Behaviour change takes time. Be patient, be consistent, and focus on the person's quality of life, and the behaviours will follow.